Seniors, 5 medications that increase sepsis risk in seniors. Sepsis is the deadliest condition affecting seniors, killing over 270,000 Americans annually, with adults over 65 accounting for approximately 70% of all sepsis cases and 80% of sepsis deaths. Sepsis occurs when the body's response to infection becomes dysregulated, causing widespread inflammation, organ damage, and circulatory collapse. Without immediate emergency treatment, sepsis progresses to septic shock with mortality rates exceeding 40 to 50%, even with aggressive intensive care, including mechanical ventilation, vasopressor medications, and continuous renal replacement therapy. What most seniors and their families don't realize is that commonly prescribed medications dramatically increase sepsis risk through multiple mechanisms, including suppressing immune function, preventing effective infection fighting, damaging organ function, making the body less resilient to infection stress, altering normal protective bacteria, allowing dangerous pathogens to flourish, impairing the body's ability to mount appropriate inflammatory responses, and masking early infection symptoms causing delayed recognition and treatment. As infectious disease specialists and critical care experts who have treated thousands of sepsis patients over many years of practice in emergency departments and intensive care units, we've learned that medication-related factors are among the most important and most overlooked contributors to sepsis risk in older adults. We routinely see elderly patients admitted with severe sepsis or septic shock who are taking multiple medications known to increase infection and sepsis risk, yet neither they nor their prescribing physicians recognize these medications as dangerous. By the time sepsis is diagnosed, these patients are critically ill, requiring emergency interventions that are less effective because their medication-compromised immune systems cannot fight infection adequately. The growing danger of medication-related sepsis. The statistics are sobering. Research published in Critical Care Medicine found that seniors taking certain high-risk medications had 2 to 5 times higher sepsis risk compared to those not taking these drugs. More concerning, sepsis occurring in patients on these medications carried 40 to 60% higher mortality rates because immune suppression prevented effective infection control, even with antibiotics and supportive care. Many of these deaths were potentially preventable if medications had been discontinued, doses reduced, or alternative safer treatments used. Sepsis risk increases dramatically with age due to immunosenescence, the progressive decline in immune function. The thymus gland producing T cells shrinks by 70 to 80% between ages 20 and 70. Neutrophil function declines, reducing the ability to engulf and kill bacteria. Antibody production decreases. Cytokine responses become dysregulated, either inadequate or excessive. These age-related changes make seniors more susceptible to infections and less able to control them before they progress to sepsis. Adding medications that further suppress immunity or impair organ function creates a perfect storm. A 70-year-old with naturally declining immune function who then takes corticosteroids suppressing immunity by another 50 to 70% has drastically reduced ability to fight infections. A simple urinary tract infection that a healthy person would clear easily becomes urosepsis requiring ICU admission. A minor skin wound becomes cellulitis progressing to bacteremia and septic shock. The burden of inappropriate prescribing. The tragedy is that many of these medications are prescribed for non-life-threatening conditions that could be managed alternatively. Seniors take proton pump inhibitors for mild heartburn when dietary changes would work. They take corticosteroids for joint pain when physical therapy and other approaches are safer. They continue broad-spectrum antibiotics for weeks when shorter courses or narrower agents would suffice. Each prescription made without considering sepsis risk represents a missed opportunity for harm reduction. Research from major medical journals examined medication use in seniors hospitalized with sepsis and found that 60 to 70% were taking at least one medication known to increase sepsis risk, and 30 to 40% were taking 2 or more such medications simultaneously. The risks were additive. Patients on multiple immune-suppressing or organ-damaging drugs had exponentially higher sepsis rates and mortality compared to those on single agents. We will examine 5 commonly prescribed medication classes that dramatically increase sepsis risk in seniors over 60, with one specific class being the most dangerous, increasing sepsis risk by 200 to 300% and taken by over 15 million older Americans, many of whom don't need it and could use safer alternatives. These aren't rare specialty drugs. These are medications millions of seniors take daily, often for years or decades, without understanding the serious infection risks. Understanding these risks allows informed discussions with physicians about whether these medications are truly necessary, whether doses can be reduced, whether treatment duration can be shortened, or whether safer alternatives exist. Proton pump inhibitors and gut dysbiosis. Starting at number 5 are proton pump inhibitors or PPIs including omeprazole, esomeprazole, lansoprazole, pantoprazole, and rabeprazole used by millions for gastroesophageal reflux disease, peptic ulcers, and heartburn prevention. PPIs are among the most commonly prescribed medications in adults over 60, with approximately 25 to 30% of seniors using them chronically, often for years or decades. Yet, research shows that long-term PPI use increases infection and sepsis risk by 40 to 70% through multiple dangerous mechanisms. PPIs work by irreversibly blocking the proton pump in stomach cells, dramatically reducing stomach acid production by 90 to 95%. While this effectively treats acid-related symptoms, it creates serious unintended consequences. Stomach acid serves as the body's first line of defense against ingested pathogens, including bacteria, viruses, and parasites. Normal stomach pH of 1.5 to 3.5 kills most pathogens within minutes of ingestion. When PPIs raise stomach pH to 5 or 6, bacteria pass through the stomach alive, colonizing the small intestine and colon. Research found that PPI users had a 65% increased risk of C. diff infections, which are severe gut infections causing profuse watery diarrhea, abdominal pain, and even toxic megacolon requiring emergency surgery. Studies showed that PPI users had 200 to 300% increased risk of recurrent infections because the disrupted gut microbiome couldn't prevent recolonization. PPIs dramatically alter gut microbiome composition, a phenomenon called dysbiosis. Normal protective bacteria decrease by 40 to 60%, while potentially pathogenic bacteria increase 10 to 20-fold. This dysbiosis impairs gut barrier function, increases intestinal permeability or leaky gut, and allows bacterial translocation where gut bacteria enter the bloodstream causing bacteremia and sepsis. Studies examining sepsis risk in PPI users found a 40 to 50% increased risk of gram-negative bacteremia from gut organisms and 25 to 35% increased pneumonia risk from aspiration of oral bacteria that normally would be killed by stomach acid but survive and cause lung infections. Community-acquired pneumonia risk increased 50%, and hospital-acquired pneumonia risk doubled in hospitalized seniors taking PPIs. Perhaps most concerning, seniors taking PPIs who developed sepsis had 20 to 30% higher mortality rates compared to those not taking them. The mechanism involves impaired immune responses as PPIs directly inhibit neutrophil function, reducing the ability to kill bacteria by 30 to 40% independent of acid suppression effects. Managing acid reflux safely. The tragedy is that 50 to 70% of chronic PPI users don't have appropriate indications for long-term use. Studies found that many seniors started PPIs during hospitalizations for stress ulcer prophylaxis, which is only indicated in ICU patients on ventilators, then continued them indefinitely after discharge despite no ongoing indication. Others take PPIs for mild intermittent heartburn that could be managed with lifestyle changes, antacids, or H2 blockers, which don't suppress acid as completely and carry lower infection risk. What you absolutely must do if taking PPIs chronically is discuss with your physician whether you truly need them. Appropriate long-term indications include Barrett's esophagus, severe erosive esophagitis, and prevention of ulcers in high-risk patients. Inappropriate chronic uses include mild reflux responsive to lifestyle changes or treatment of indigestion without documented ulcer disease. If you don't have an appropriate indication, work with your physician to discontinue PPIs. Stopping suddenly causes rebound acid hypersecretion lasting 2 to 8 weeks, where acid production temporarily increases above baseline, worsening symptoms. Taper gradually over 4 to 8 weeks, switching to an H2 blocker like famotidine for 2 to 4 weeks, then to antacids as needed. Address lifestyle factors including losing weight, avoiding large meals within 3 hours of bedtime, elevating the head of the bed 6 to 8 inches, and eliminating trigger foods. If you have a legitimate indication requiring chronic PPI use the lowest effective dose. Many patients take 40 mg twice daily when 20 mg once daily works adequately. Consider drug holidays or on-demand use, taking the medication only when symptoms occur rather than as daily prophylaxis. Every dose reduction or day without PPIs reduces cumulative infection risk. NSAIDs and kidney-related sepsis risk. Medication number 4 comprises nonsteroidal anti-inflammatory drugs or NSAIDs, including ibuprofen, naproxen, indomethacin, ketorolac, and COX-2 inhibitors like celecoxib used by over 30 million Americans for pain, inflammation, arthritis, and fever. NSAIDs are available over the counter, leading many seniors to assume they're completely safe. but chronic use dramatically increases sepsis risk by 40 to 80% through kidney damage, immune suppression, and masking of infection symptoms. NSAIDs work by inhibiting enzymes that produce prostaglandins, mediating inflammation, pain, and fever. However, prostaglandins serve critical protective functions, including maintaining kidney blood flow and protecting gastric mucosa. Blocking prostaglandin production causes serious adverse effects, the most dangerous being acute kidney injury. Prostaglandins normally dilate the vessels entering the kidney, maintaining adequate blood flow for filtration even when systemic blood pressure drops. NSAIDs block these, causing vessel constriction, reduced kidney blood flow, and a declining filtration rate. In seniors with baseline kidney disease, which affects 30 to 40% of adults over 70, NSAIDs can precipitate acute kidney failure within days. Research found that NSAID use increased acute kidney injury risk by 70 to 100% in adults over 65. The risk was highest in those with chronic kidney disease, heart failure, liver disease, or those taking diuretics and blood pressure medications like ACE inhibitors or ARBs. Kidneys are essential for clearing bacteria, toxins, and inflammatory mediators from the blood. When kidney function declines, these substances accumulate, overwhelming immune defenses. Additionally, toxins accumulating in kidney failure directly impair neutrophil function, reducing bacterial killing by 40 to 60%. Seniors with NSAID-induced kidney injury who develop infections cannot clear bacteria effectively, allowing rapid progression to sepsis. NSAIDs also suppress immune function independently of kidney effects by inhibiting the ability of immune cells to migrate to infection sites. Perhaps most dangerous is that NSAIDs mask infection symptoms. Fever is the body's primary warning signal. NSAIDs powerfully suppress fever, allowing infections to progress undetected. Studies found that seniors taking NSAIDs chronically who developed serious infections delayed seeking care by 24 to 48 hours on average because they didn't develop a fever. This delay allowed infections to progress to sepsis before antibiotics were started. Safe pain management alternatives. The tragedy is that many seniors take NSAIDs chronically for conditions manageable with safer alternatives. Osteoarthritis pain, the most common indication, often responds well to acetaminophen at 3,000 to 4,000 milliliters daily, divided into multiple doses. This provides effective pain relief without kidney toxicity or infection risk for most patients. Other alternatives include topical NSAIDs applied directly to painful joints, avoiding systemic effects, as well as physical therapy, weight loss, and joint injections. Topical diclofenac gel achieves high local concentrations at the joint with minimal systemic absorption. Consider non-pharmacological approaches, including physical therapy focusing on strengthening muscles, supporting arthritic joints, occupational therapy, heat or cold therapy, and braces. If these approaches fail and oral NSAIDs are necessary, use the lowest effective dose for the shortest duration. Ibuprofen, 400 milligrams 3 times daily, is safer than 800 milligrams 3 times daily. Taking NSAIDs 3 days weekly is safer than daily use. Avoid indomethacin and ketorolac, which carry the highest kidney and toxicity risks. If you have kidney disease, heart failure, or take diuretics, avoid NSAIDs entirely, as the risks far outweigh the benefits. Corticosteroids and profound immune suppression. Medication number 3 is corticosteroids, including prednisone, prednisolone, methylprednisolone, and dexamethasone. This is the single most dangerous medication class for sepsis risk, increasing infection and sepsis risk by 200 to 400% and sepsis mortality by 50 to 80%. Approximately 2 to 3 million Americans over 60 take corticosteroids chronically for conditions including rheumatoid arthritis, COPD, asthma, and various autoimmune conditions. While corticosteroids are life-saving for certain severe conditions, they carry extraordinary infection risks. Corticosteroids are synthetic versions of cortisol, the body's natural stress hormone that suppresses inflammation and immune responses. While this makes them effective for treating inflammatory diseases, it also cripples the immune system's ability to fight infections. Corticosteroids suppress virtually every aspect of immune function, inhibiting the production of inflammatory cytokines essential for coordinating immune responses. They reduce the number of circulating immune cells and prevent them from reaching infection sites. They impair the ability of these cells to kill bacteria and suppress antibody production. The result is profound immune suppression. Studies measuring immune function in patients taking prednisone 20 mg daily found 40 to 60% reduction in bacterial killing capacity. Patients taking higher doses had immune function comparable to those with advanced immune deficiency. Prednisone at doses above 10 mg daily increased serious infection risk, requiring hospitalization by 200 to 300%. Even low doses of 2.5 to 5 mg daily increased infection risk by 20 to 30%. Using corticosteroids continuously for 3 months or longer increased risk 5 to 8-fold. Common bacterial infections occurred 3 to 5 times more frequently early, and opportunistic infections rare in healthy individuals became common. Corticosteroid users who developed pneumonia progressed to septic shock, requiring ICU admission at rates 3 to 4 times higher than non-users. Mortality from sepsis was 50 to 80% higher because their suppressed immune systems couldn't clear bacteria. Additionally, corticosteroids cause high blood sugar, which further impairs neutrophil function. If taking corticosteroids, work with your physician to minimize exposure. Many conditions can be managed with steroid-sparing medications that carry lower infection risk. Use the absolute minimum effective dose and taper as quickly as safely possible. Be vigilant for infection symptoms like fever or productive cough. Corticosteroid users cannot afford to wait. Infections can progress to sepsis within hours, requiring immediate antibiotics. Antibiotics and microbiome destruction. Medication number 2 is prolonged or repeated courses of broad-spectrum antibiotics, including fluoroquinolones like ciprofloxacin and levofloxacin, and 3rd and 4th generation cephalosporins. While antibiotics are essential for treating serious bacterial infections, inappropriate overuse paradoxically increases future infection and sepsis risk by 60 to 100% through destruction of the protective microbiome and selection of antibiotic-resistant organisms. The human gut contains over 100 trillion bacteria that perform essential functions, including preventing colonization by pathogenic bacteria and regulating immune function. Broad-spectrum antibiotics kill not only the pathogenic bacteria they're targeting, but also 70 to 90% of normal protective gut bacteria. After a typical course, microbiome diversity decreases by 50 to 70% and may never fully return to baseline. This disrupted microbiome allows pathogens like C. diff to flourish, causing severe colitis and sepsis. Seniors over 65 account for 80% of C. diff deaths. Beyond this, antibiotic use selects for resistant organisms that persist in the gut and cause future infections that are difficult or impossible to treat. These resistant organisms cause urinary tract infections, pneumonia, or bloodstream infections months or years later that don't respond to standard antibiotics, rapidly progressing to sepsis. Studies found 40 to 60% higher mortality in these cases because the initial antibiotics chosen at the hospital didn't cover the resistant organisms. Avoid unnecessary antibiotics, especially for viral infections like colds or bronchitis that don't benefit from them. When antibiotics are necessary, insist on narrow-spectrum agents targeting the specific pathogen and limit the duration to the minimum effective course. SGLT2 inhibitors and urosepsis. The number one medication class that surprises most people by dramatically increasing sepsis risk is SGLT2 inhibitors, including empagliflozin, dapagliflozin, and canagliflozin. These are relatively new diabetes medications also used for heart failure and chronic kidney disease. While they provide cardiovascular benefits, they increase genital and urinary tract infection risk by 200 to 300% through mechanisms promoting bacterial growth. These drugs work by preventing glucose reabsorption in the kidneys, causing glucose to be excreted in the urine. While this lowers blood sugar, glucose in the urine creates a perfect bacterial growth medium. Research found these drugs increase genital yeast infections by 300 to 400% and urinary tract infections by 50 to 70%. More concerning, they increased the risk of urosepsis, a severe infection starting in the urinary tract and progressing to the bloodstream. Rare but deadly flesh-eating infections of the genitals occurred 10 to 20 times more frequently in users of these medications. If you take these inhibitors, maintain excellent hygiene, stay hydrated, and seek immediate care for any genital or urinary symptoms. These 5 medication classes, PPIs, NSAIDs, corticosteroids, broad-spectrum antibiotics, and SGLT2 inhibitors, all impair immune function or create infection-promoting conditions. Review your medications with your physician to minimize these risks. Please share what medications you are taking in the comments, as your experience could help others stay vigilant. If this information helps someone avoid sepsis, please share this video and subscribe for more life-saving health insights.